نبدأ على طول. I'm glad to share the session about community-acquired respiratory tract infections, and I'm very happy to introduce Professor Logi, who is one of the most eminent professors in this field, and who is going to address us today an overview of the evolving and mutating worldwide bugs and viruses affecting the respiratory tract.
Mr. Chairman, ladies and gentlemen, dear colleagues, it's a great pleasure to be here again. I think last summer I lectured already here in the hospital university clinic, and I thank the organizers for inviting me. So let me start with my agenda, and I will start with COPD and exacerbation of COPD and bacterial bronchitis. I will go then to new insights in the bacteriology of exacerbation, position of antibacterial therapy. There is still some controversial issues in this field, and also I will discuss CAP and severe CAP, mono versus combination therapy, and what are the places of corticosteroids in community-acquired pneumonia. Here you see a picture from Berlin, my home city, 250 years ago, and you see a very clear situation in one of the main streets unter den Linden, and at this time I was told we didn't have any chronic bronchitis. You know that chronic bronchitis is very much connected with smoking, and the definition of COPD, I think, is very familiar to you. Is a preventable and treatable disease, and by airflow limitation that is not fully reversible. And the airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases, primarily, as I mentioned already, cigarette smoking. And we know that COPD, which is on the 5th and 6th place now, when you look at the statistics of the global mortality, will move in the next 10 to 15 years on place number 3. So I think it's a very important disease, and in your Congress here, I saw that you will really discuss any of the main and very important issues of this disease. Well, we have not a new definition of exacerbation. We are still going with the old Antonisen definitions of increased dyspnea, increased sputum volume, and increased sputum purulence. However, in the last 10 years, we think that the increased sputum purulence is a very important factor. But on the other hand, we also know that, and I will show you some of these data, that if a patient is suffering the type 1 exacerbation, where he has all 3 cardinal symptoms, then I think antibiotic treatment is an appropriate approach. We have a new definition of the exacerbation, because when you look through the literature to the different papers, you will not have the same definitions of the exacerbation. So I took the latest definition in the Gold Amendment paper, and it was written that this is an event in the natural course of the disease characterized by a change in the patient's baseline dyspnea, cough, and or sputum that is beyond the normal day-to-day variations, is acute in onset, and may warrant a change in regular medication in a patient with underlying COPD. However, it is not clear how much of the change is necessary to accept that the patient has an exacerbation. So that is still a matter of discussion. What are the etiologies of ASCB? There is no change. We know that about 20% is coming from non-infectious factors like the environmental or non-compliance with medication, and about 60 to 80% are by bacterial pathogens, viruses. Very frequently viruses start the infectious exacerbation, and the position of atypical bacteria is still a controversial issue. The UK colleagues didn't accept atypical as etiologies, but for example, some Italian colleague, they have some data which show that about 3 to 5% may be chlamydia or mycoplasma. The causative pathogens in the exacerbations, we know since many decades that the big three, H. influenza, Streptococcus pneumonia, and Branhamella, are the leading pathogens. However, we have now some insights from different groups, and we were the first group who published in 1998 already in the chest that in accordance to different severity stages, you have also different pathogens. That means if you have an FEV1 between 50 and 70% predicted, you may go with the pneumococcus and the normal flora. But on the other side, if you have the gold stage 3 and 4, you will find more Pseudomonas and Enterobacteria. And this is now confirmed in many studies, and our first data came from a retrospective study, but then we made and performed a prospective study, and we published these data, which were exactly the same data as we found with the retrospective data, and we published this in the journal Infection 2 years ago. Also, the group from Dr. Sethi from Buffalo, upstate New York, published very interesting data, also confirmed the Pseudomonas finding of our group. But the main finding of the data from Dr. Sethi published in the New England Journal of Medicine was that with a lot of new exacerbations, you have new strains of pathogens. So the old belief that the same strain will be in the distal bronchial airways is not true anymore. There is a change of the serotypes, and especially also when you look at Moraxella catarrhalis, but also with H. influenza, you have new serotypes. So the persistent continuous colonization, which we believed was the case until these data, is not true anymore. So what is the therapeutic approach in exacerbations? We have certainly steroids. We have, at least unfortunately in Germany, we still are going in the outpatient setting with theophylline. We are using an increased dosage of inhalative anti-obstructives. And what is the place of antibiotics? And this I want to discuss a little bit more in detail. Which patient should have antibiotics? And here is a very useful table from Marc Mirovitlis from Barcelona. And what he did, he told us, look at the color of the sputum of our patients. And with these differences, if you have the purulent exacerbation, this color, you have a positive sputum color in 90%, you have high bacterial number, and also when you look at the inflammation parameters, myeloperoxidase or leukotriene B4, they are all elevated. And this is in contrast to the mucoid sputum, where you have only very low numbers of bacteria, where you have low culture findings, and where also the inflammation parameters are very low. So the simple message from this inspection and from putting all these scientific data together was that the purulent sputum, these patients should have antibiotics. And we should discuss whether this is true. There is a new study from Holland where they again challenged the indication for antibiotics in exacerbation of chronic bronchitis. And they gave their patients steroids, admitted patients to the hospital, and in addition placebo or doxycycline. And what you can see here, and this was the message of this study, when they looked at day 30, they found no statistical difference regarding the treatment failures on day 30. But when you look here on day 10, there was a significant difference in favor of an old antibiotic like doxycycline, which may be not a super antibiotic for these patients. And when you look a little bit more in detail in this study, and look, for example, on day 10, you see here that the type 1 exacerbation, 3 parameters positive, there you have clearly an effect on day 10, which is always also the time when you can leave the patients from the hospital. And also when you look at bacterial presence, serum CRP, when it's very high, there's a clear statistical difference in favor of antibiotic treatment. So I think that the time point, 30 days, is for this kind of patients, is not an appropriate time point. So you see here, even with an old antibiotic, there are a lot of positive aspects with antibiotic treatment. And especially when you also look in detail to day 30 and look at the different parameters, always you have a tendency in favor of the antibiotics. And especially in those patients where you have very high CRP, where we have the suspicion that you may have also a peribronchial infiltration, there you see a positive aspect of the antibiotic treatment. So my conclusion of this study is exactly the other way around than it is written in the Blue Journal. Another new approach to safe antibiotic treatment and to define the patients with exacerbation is the usage of high-sensitive procalcitonin. And this is a study which was recently published in the Lancet in February this year, and these were patients in the ICU, and all these patients received procalcitonin measurements during their very severe exacerbation. And what you can see is that those patients who had a controlled measurements continuously of the procalcitonin had less antibiotic usage in comparison to the normal treatment. So procalcitonin can save the usage of antibiotics. And to give you only one impression, and don't go to this table, I will make it very short. We now have a lot of data which demonstrated very convincingly that the usage of procalcitonin can save antibiotic usage, can save resistance development without increasing mortality. And you see here, and I will lead you to this reference where you can see all these references of this table, where you can find, if you are interested, all the data on procalcitonin regarding exacerbation of chronic bronchitis and also other respiratory tract infections. Coming back to a Cochrane collaboration analysis, again, what is the position of antibiotics? And what they found in 11 comparative studies, antibiotics versus placebo trials, that the use of antibiotics reduced the risk of death by 73%. Isn't it impressive? I think, yes. Reduced risk of non-response to medical intervention by 53%. Reduction of colored pool and sputum by 44%, at a cost of increased risk of diarrhea. So the conclusion of the Cochrane analysis was that antibiotic usage in COPD patients who are moderately to severely ill with pool and sputum and increased cough is really indicated. So what are the guidelines? And I took the guidelines from 2005. There will be new guidelines next year from the European Respiratory Society. And you see here that clearly the type 1 and the type 2 exacerbation with purulent sputum is an indication for antibiotics. And maybe in the future, using high-sensitive procalcitonin, we can stratify this even further. So what are the recommendations? You see here, with a mild COPD exacerbation where you have these leading pathogens, usually you can, with the type 3 exacerbation, you can save antibiotics. You can save antibiotics if you have a very low procalcitonin. Otherwise, you have to use amoxicillin tetracycline regarding your local resistance patterns. Coamoxiclav, macrolide, or a modern fluoroquinolone in countries where you have already high penicillin resistance of the pneumococcus, high tetracycline resistance of the pneumococcus or H. influenza are very, I think, alternative possibilities. In the group C, patients who are mostly treated then in the ICU, ciprofloxacin high dosage is the appropriate therapy. And in the group B, those are the patients who you see mostly on the normal ward in the hospital. There, I think, there coamoxiclav or a modern fluoroquinolone is or are the recommended antibiotics in this setting. A very new study published in JAMA also looked what is the optimal timing of antibiotics in exacerbation of chronic bronchitis. This was a very big study of Dr. Rothberg and co-workers, and they took more than 80,000 patients in a retrospective analysis, and they looked whether an antibiotic treatment of patients with COPD exacerbation in the first 24 hours did give better results than starting the antibiotic treatment on day 2 or later. And what you can see here in this slide is that late ventilation, in-hospital mortality, and treatment failures were more frequently in those patients where you waited too long with the antibiotic treatment. So the message of this study was start as early if you have a purulent exacerbation of your COPD patients in the hospital. It gives you better results, again, supporting the appropriate treatment with antibiotics. Second part of my talk, let me go to community-acquired pneumonia. And I will not go in this slide anymore, it's very familiar to you, but what I want to discuss very shortly is that in accordance to the radiographic chest signs and symptoms of the patients, you cannot be certain what is the pathogen. The radiographic picture can give you only a hint, and can you not tell this is a pneumococcus, this is a Legionella, or this is H. influenza. What are the factors influencing survival in CAP? On the one side, these are the hosts and all the factors of the host. These are the strains, especially virulence factors, but also resistance. Different serotypes of pneumococcus have different virulence. And the antibiotic therapy, as we just discussed with COPD exacerbation. What is the optimal timing for the antibiotics? What about discordant therapy in bacteremic pneumococcal diseases? So these factors together will influence the survival of our patients with CAP. And one information which came out in the last few years from the very big German surveillance study. This surveillance study, the so-called CAPNet study, has now collected nearly 10,000 patients, starting 10 years ago. And one aspect which I found very interesting regarding the mortality of our CAP patients was when you look at the statistics, in the more severe cases where you have a CURB 3 or 4 or more, those patients are all dying, most of them, 90% are dying in the first 4 days. What does this mean? I think there are many explanations, but two are leading. One is the patients are admitted too late to the hospital. So we have to educate our colleagues in the community to send the patients with risk factors earlier to the hospital. And the other factor may be that at this time, and we will discuss this in some minutes, at this time, the antibiotic treatment is not very successful. There may be more factors which are responsible for this bad prognosis of these patients. What are the etiologies regarding the bacteriology? You see here that in the ambulatory patients, hospitalized patients, severe ICU patients, the Streptococcus pneumonia is always the leading pathogen. So any empiric treatment has to cover the pneumococcus. Then you have some differences, and I think you are familiar that, for example, in the ICU patients, Staph aureus, Legionella, also some gram-negative pathogens have to be covered from the early moment. What about severe CAP? Again, Streptococcus pneumonia is a leading pathogen, but H. influenza, Legionella, and Staph aureus are also to be considered for the empiric treatment. And this is also true in a recent study from Europe, where in 17 different ICU in CAP patients who are suffering from severe sepsis and sepsis shock, the pneumococcus in all these patients was the leading pathogen. So in these patients with severe pneumonia, the optimal choice of an antibiotic is very important. And I prefer the guidelines from the United States, from ATS and IDSA together. And they have a very simple recommendation. In the inpatient, in the general ward, respiratory fluoroquinolone, strong recommendation, or a beta-lactam plus a macrolide, so a combination treatment. In the ICU patient, beta-lactam plus azithromycin, or a beta-lactam together with a fluoroquinolone, a level 1, and here a level 2. And let me shortly comment on a very successful drug in this field, that is amoxifloxacin. Moxifloxacin, and we will have a press conference after my talk here in this room, is one of the best investigated antibiotics in the last 20 years. The company Bayer Schering has now more than 15,000 patients in prospective randomized studies. That is something which I'm appreciating very much. They have performed different studies with different endpoints. The target study, for example, they looked for moxifloxacin in comparison to amoxicillin clavulanic together with clarithromycin. And they saw equivalence of their drug. In MoxiRapid, they looked how fast is the response of the patients when they are treated with moxifloxacin versus standard treatment. And they could easily show that the time to defervescence was significantly shorter with moxifloxacin than with the comparators. In Capri, a study which was induced by the FDA, they had to look in comparison to levofloxacin whether in patients with an age above 70 years more cardiac toxicity were seen, and this was not the case, and moxifloxacin was as active as levofloxacin in high dose. And the most impressive study, where I was also in the committee to make the final judgment, was the MOTIVE study. In the MOTIVE study, patients with severe CAP were treated with moxifloxacin alone versus ceftriaxone together with levofloxacin, a very potent combination. And the results showed no differences. So I think Moxi showed already in many very well-designed studies how effective this drug is. And this drug in Germany is now for 10 years available, and more than 130 million people or patients are treated with this drug, and therefore, as a German, I think I have to congratulate the company for this success. What about the impact of atypical pathogens in this disease? This is a study from Dr. Arnold and co-workers from the group of Ramirez in the United States, where they looked in different parts of the world how frequent are atypical pathogens. And what you can see that between 20 and 28% in any of the countries in the world, the people found in prospective studies atypical pathogens involved, mostly Mycoplasma, Chlamydia, and Legionella. And the question was, do we have to cover atypical pathogens in the empiric first treatment? And the results are very clear. When you look at the total mortality in those patients where you had a coverage of the atypicals with macrolides or with fluoroquinolones, you could see that the mortality was significantly lower. And when you look at the CAP-related mortality, you had the same picture. So the coverage of atypicals is very important. And in some study, it was also true that the combination with macrolides gave some additional positive results in this combination. And when you look, for example, only on the anti-inflammatory effect, on the host reaction with the macrolides, we have a pro-inflammatory cytokine production which is inhibited. We had an inhibition of adhesion molecule expression and additional factors also on the pathogens. So the macrolides have, besides direct effect on the pathogens, also additional effect on the immune response of the host. So this may, to some extent, explain why macrolides are so successful in combination treatment. And this was shown in many studies, and I will show you only 2 studies. This was one of the landmark studies from 2004 from the group from Badur and Yu, but this was an international study where they looked in more than 700 cases with pneumococcal bacteremia in critical ill patients. And what you see here is, if you made an analysis of all patients together, a combination therapy versus monotherapy, no differences. But when you look at the more severe cases, on the severely ill patients, you saw that the combination therapy was significantly more successful. And this was also true in a study from Spain, where the combination therapy in ICU patients with CAP were also statistically more effective than monotherapy. Last point, what is the efficacy of corticosteroids? And let me go back to the statistics of the high mortality of our CAP patients admitted to the hospitals in the first 3 or 4 days. The approach is, should we inhibit the inflammation over response of our patient? Could we use corticosteroids to inhibit this over response? And this was a study from the Netherlands, and what they did, they gave those patients, in addition to antibiotics, placebo or prednisolone in a prospective randomized double-blind design. And you see here the 2 different groups. They had amoxicillin or moxifloxacin, similar in both groups as the leading antibiotic treatment. And then what were the results of this study? But you can see, and to make a long story short, no differences at all, whether the patients received steroids or not. So this is still a controversial issue because we have some limiting data from short prospective studies which showed positive aspects. So I think we need at least more prospective, big randomized study to solve this problem. So, Mr. Chairman, ladies and gentlemen, let me summarize. What are the new aspects in lower respiratory tract infections? I think the controversial discussion whether patients with pulmonary exacerbation needs antibiotics is now finished. High sensitive procalcitonin may give us more insights to save antibiotics in specific patient groups. Early antibiotic therapy in COPD exacerbation is recommended, and in the more severe CAP patients, combination therapy is more effective than monotherapy. And thank you very much for listening, and I will stop here.
Thank you very much, Professor Ludi, for this very comprehensive and attractive talk about the common pathogens affecting the respiratory tract. And now, if there is any questions, we have 5 minutes for any question to Professor Ludi. So thank you very much, and we close this session. Thank you.
Thank